I'm going to give a presentation that's similar to what I give at some of the medical congresses that I speak at, but it'll be a little abbreviated, and then there'll be time for questions in the end if somebody is a medical professional in the audience and they want to ask something specific about maybe a patient they have or a certain patient population that they have. That's great. Also, anything that's very specific to you, we'll kind of keep that to after the main question section, and I'll be here the rest of the evening, so you can just come up to me. That's me, John Jaquish. I'm a PhD, not a medical doctor, so I focus on research. I don't see patients, so I'm not qualified to give anybody any medical advice on any level. I will always say speak to your physician. It doesn't matter really what you ask me, though I'm funny when it comes to that answer, so sometimes you should ask me where the best restaurant in town is, and I'll say speak to your physician. I also want to thank some of the other leaders in the world on this, Professor Rai Kunikander, Lynn Freeman, I'm going to talk a little bit about him in the middle of the presentation, and Professor Corey Huck have been guys who really helped encourage me jump in and take this in a different direction, because the standard of care for osteoporosis has been pharmaceuticals, and there really hadn't been a physical medicine approach. And I felt, and as I'll tell the story, I felt like there was an obvious one that we were missing, but the industry of osteoporosis just didn't come from the physical medicine background. They came from pharmaceutical backgrounds. So I had a fresh approach, and these are the guys who encouraged and have co-authored some of the research with me. I always mention the limitations of what data we have. It's very important that everybody walks away knowing what we have, and it's almost more important what we don't have. So this is a physical medicine intervention, which is like a physical therapy or an exercise. And the type of data and volume of data that is seen and that is specific with a lot of these interventions is not at the same level of pharma. So when somebody says there's such and such medication has been studied with millions of people, and there's been thousands of studies. Now, I will talk about later what the library of literature is on the loading of the musculoskeletal system and what bone density results have been seen. You'll be surprised at how much data there is, but it's not necessarily to the same level. Also, I'm going to be talking about who this treatment, this system is not for. There's nothing out there works for absolutely everyone. So we're going to be talking about contraindications and then other populations that it may just not be the right fit for. A little bit about osteoporosis and low bone density. 1 in 3 females and 1 in 5 males are affected by this. And the takeaway that I like leaving people with is this actually ends as many lives as breast cancer does. It's not seen that way necessarily because it has to do with complications. Somebody breaks a hip, they go to the hospital, and then there's complications because they can't move around, they can't get enough air into their lungs. I see a bunch of people nodding. Most people know somebody who had a fragility fracture, went to the hospital, and never really recovered from it, or had a very poor quality of life afterward. So that's the takeaway. Now, we're not just talking about osteoporosis. In fact, at OsteoStrong, we talk about bone health, not about osteoporosis. Same subject, but we're looking to improve the health of bone, which is increasing bone density and the associated reduced risk of fracture, potential reduced risk of fracture, but we don't specifically speak about disease condition because, again, as Lane mentioned, we're not a medical facility. This is physical medicine, and we're improving the health of bone. Now, how this started, as Lane mentioned, my mother was diagnosed with osteoporosis. She's adorable. Yeah, so the story goes, I came home from college, and she was very upset, and she said, well, I'm going to die. And she's dramatic, so I'd heard that before. And so I said, well, why? Well, I was diagnosed with osteoporosis, and I thought, okay, well, that's a real thing. So unlike some of the other things that she said she was going to die from. So I said, well, let me do some reading, you know. I said, I want to do some reading and learn a little bit more about this. And what I learned was that osteoporosis is a disease of deconditioning. So when a muscle gets weak, we call that sarcopenia. But that's not really a disease necessarily, because you can exercise, you can recover that muscle. Or you can figure out why the nutrients aren't getting into that muscle necessarily. And you can recondition something that becomes deconditioned. And so what I said to her was, what if I figured out a way to recondition the bone? And she's very agreeable. So I could have said anything. So she said, yeah, sounds great. So what I started doing was looking at different populations, athletic populations, that had the highest levels of bone density. And this project was very easy because there is one population that has incredible high bone density. They also have the highest instances of fracture, and it's gymnasts. So gymnasts, the way a gymnast hits the ground is very consistent every time. There's other high-impact sports that have variability in how they contact the ground, but with gymnasts, the way they land is very similar. They're very, very focused on the landing biomechanics. And so they have very high bone density, but they also have very high instances of fractures. In fact, most gymnasts retire at 19 years old, and it's because of the risks of injury. So the conclusion I came to was, why don't I just create a series of devices that gives us the benefit of high impact without the risks of high impact? So very slow and controlled loading, computer monitored. I was in the software business at the time. This is my college job. And so that's exactly what I did. So I built a biofeedback system, which you see right here. There's 4 devices. And what this allows individuals to do is get into a position they would naturally absorb high impact force. And there's robotic arms that drive all of these devices to get in exactly the right position, and then allowing the individual to self-impose load in a very slow and controlled way. So who here has used the devices already? Okay. For those of you that haven't, this is not like a weightlifting experience. It's more like a yoga type experience. Very slow, very controlled, listening to your own comfort. In fact, if you're not comfortable, you have something called neural inhibition, which is where your central nervous system starts shutting muscles off, and it doesn't work. So you have to be comfortable. So it is important to point out that within 18 months of developing the prototype, my mother she had almost a T-score of 0. So she went right from the diagnosis level, negative 2.5, to 0, and she was in her 70s. Now she's 81, and she still has a T-score of just under 0. It's like negative 0.3. So this is what somebody looks like when they're under load, unloaded, at rest. This is in pounds, 113 pounds. And then at load, 1,053 pounds. This is a postmenopausal female. And she is putting 8.1 multiples of her own body weight through her hip joint. Now, once I started publishing this type of data in different journals, in different academic journals, I met some individuals at the World Congress on Osteoporosis, and what they said is, well, we don't even really know what the minimum dose response is for bone growth. So what that means is the term minimum dose response, this is a fun fact. You'll dazzle your friends at cocktail parties with this. So when something new is created, whether it's a physical medicine or pharmaceutical medicine type thing, the researchers want to figure out what's the minimum amount that we give to somebody to create the effect that we want. It's not like they just come up with something and they go, 500 milligrams, why not? That's not how that works. So what they wanted to determine was, like, exercise and high impact type force was always recommended for osteoporosis patients, but no dosage associated. So people would go and walk and say, why do I still have osteoporosis? So what they did was these Deere and researchers in 2012, they would tape accelerometers right on the hip joint. And then they would tell people to go through high impact protocols, whether it was dance class or go play soccer. It was done in the United Kingdom, so I'm guessing they played soccer. That wasn't in the methods section of the study, though. It said activities, athletic activities. So I just have a picture in my head of that. So whatever they did, they looked at the individuals, and this is a wide breadth of age. And what they determined was the people that exceeded 4.2 multiples of their body weight had bone turnover that was more positive. So you're always losing and gaining bone at the same time. This is metabolic rate, all cells in your body. And so what they wanted to see was that the breakdown got lower than the building, because after 30 years old, typically it's the other way around. So what they determined is the people who loaded 4.2 multiples body weight through their hip were building bone. The people who did not change that ratio. So that coincides with everything that we see with what we're doing here, in that we're enabling people to isolate the positions of high impact, which is what that study was looking at, because that's the only place you get the highest peak forces, and allowing the individuals to self-load in a controlled manner so that they can potentially trigger bone growth. And I say potentially, I'll get to why I say that later. So when we look at some of the data there was a study at the Stratford Village Surgery in East London. And what they did is with 55 subjects, they looked at bone density over 6 months. There was a 2-month lag just because of the way the national health system works in the United Kingdom. So it was really 8 months of time they went through, and they showed 14 and 15% increases in hip and spine, respectively. I wasn't involved in that study other than writing the protocol, basically teaching them, like, this is the way you do the therapy, and I was out of it, so there was no conflict of interest in that study. And then later on, there was a follow-up study which used statistical tests to look at the level of loading and then look at how consistent that was with this study, and that was done with 2,300 people. So we saw with statistical significance that this large population was able to, with a 95% confidence, able to get to the levels of force that were associated with triggering bone growth that we saw in the first study. So there was an earlier study that I did with the very first people. Now I did this one, and then the British government did this second one. But we compare it to the standards of care here. Now this is average of 12 months, and this was taken from multiple meta-analyses. A meta-analysis is when you take all the research on one subject and try and condense it using statistics into one answer that might get you closer to what the real answer is. Takes bias out of different studies. And so this is a combination of 150 different peer-reviewed studies aside from the OsteoStrong stuff. So we see a non-active lifestyle with calcium and vitamin D, walking, whole body vibration, exercise, bisphosphonate therapy. That's the most commonly prescribed drug therapy. And then there's bone anabolics. Teriparatide is the only one that's FDA approved at the moment, though there's some others. That's reserved for people who are like imminent fracture risk. So I don't know. A little bit of it depends on where you are. In Nordic countries, they tend to prescribe this more than in the United States. And then here are the two things. Here are the two studies for osteogenic loading. So as you can see, most people are still losing. Walking and no activity with calcium and vitamin D and whole body vibration by itself, they were all the same. So with calcium and vitamin D, the loss was slowed down a little bit, but they were still losing in a 12-month period. A little bit of gain with weight training, and then we have the other solutions, but it's important to see that by comparison. Now, this is another thing that's fun at cocktail parties. You can have this application on your iPhone. It's called Fracture Proof. And what it does is you enter your body weight, and you hold the phone. You create an account, and you enter your body weight. You hold the phone on your hip, and you can jump and land. And the accelerometer, it's meant to replicate the study that was done in Bristol, United Kingdom, to tell you if you're able to put enough force through the hip to trigger bone growth. Now, I can save you all $2 and tell you it's really hard to get 4.2 multiples of body weight through the hip joint without giving yourself some significant exercise risk. So you could stand up on the chair and jump off, and maybe you'll get there. A lot of people, you wouldn't recommend that they do that. So it's interesting. You put it on your phone, and you have your phone held against your hip, and you jump and land. It might be or 1.6 or something like that, but it's not going to be 4.2 multiples body weight. So interesting tool. Also, the tool benefits American Bone Health, which is a nonprofit organization, education organization. I was on the board of that organization for years. So they're the #1 patient education institute in the world for osteoporosis and bone health. Now, type 2 diabetes, I'm going to briefly go over this, and this is a massive simplification of how type 2 diabetes works and how this works with type 2 diabetes. Anybody that has detailed questions, come and see me. Like there's probably an endocrinologist that would have all their hair fall out if they heard me simplify it to this level. I like saying that because, So 1 in 5 healthcare dollars are spent on metabolic disease, which is like the category of type 2 diabetes, pre-type 2 and type 2. What is going on is blood glucose gets to levels that are not healthy for the rest of the body, and you want those levels to come down. Now, what we saw, the same hospital in the United Kingdom, in East London, took 20 subjects age 62. They were pre-type 2, and it's important that they were pre-type 2 because you don't want to take somebody who is diagnosed with type 2 and tell them not to take any medication and not to control their nutrition. That would be unethical. So these are people who refused to change their nutrition and also refused any type of medication at all. So that way we could control we could only introduce one variable and see what the difference is. So this is what's called a monotherapy study. I actually thought when they started doing this it would be difficult to find people who just absolutely refuse to change their lifestyle. Not really, especially not in East London. So as a monotherapy, and I compare it to other monotherapy studies, now you'll see studies with type 2 diabetes medications that people are taking metformin, maybe a new drug. Metformin is kind of the standard of care, and they're also doing calorie restriction, and they're doing cardiovascular exercise. So these things are stackable, but for just isolation purposes, we're looking at it as a monotherapy. So we saw reductions. I know the bar is going up, but it actually represents a reduction. Reductions of hemoglobin A1C that were stronger with OsteoStrong as a monotherapy than all the other standards of care. Now, if somebody were pre-type 2 or type 2, we would encourage them calorie restriction, and if they were prescribed metformin, that's a very, very low side effect, almost no side effect. In fact, it's refined French lilac if you want to know what metformin is made out of. Kind of a great pharmaceutical. But these things can go together, be stacked on top of each other, and for even better results. Now, what's really interesting about the mechanism of what we're doing with looking at metabolic dysfunction, the type of muscular change that happens when you use OsteoStrong is what's called a myofibril hypertrophy. You're not going to need to remember that. But what it's doing is it's increasing the density of the cell. That doesn't mean you get more cells. Don't ever misquote what we do here. You don't divide cells. What you do is there are contractile proteins within the cell, and those are called myofibrils, and when those start to grow, the density of the cell changes. And with somebody who is suffering from metabolic dysfunction, you're going to need that.
I'm sorry.
When somebody has metabolic dysfunction, they have damaged insulin receptors within muscle. But when we're creating protein synthesis, we're creating fresh new ones. And so this can actually work on a semi-chronic level when this type of adaptation happens, and that's what's being depicted in a very simple way here. So we see it versus strength training. Now, strength training can have a similar effect for a much more temporary period of time, because what's going on is you're making the insulin receptors work harder that are working, but you may not create the same volume of new ones that you would with this type of very high loading in the most engaged position type fatigue of cell. Some of the other things that happen with osteogenic loading. Now, this is not necessarily the typical result. This happened in 7 weeks. This is the most extreme example I've seen, but I've seen it happen in 7 months with lots of different people, where there's an exaggerated kyphosis, and she just happened to be wearing the same garment, and the person operating that center took 2 pictures. But she feels like her life's been changed completely, because you can imagine she breathes better, she moves better, she's able to carry her groceries, play with her grandkids. And what ends up happening is her spine, like when this exaggerated kyphotic curve happens, what happens is the vertebrae thin on sort of the inside. That's still there. That's a shape change of the vertebral body. We have no reason to believe that that would change, and I've seen pre and post x-rays. But what's happening that show that that's still there, what's happening is the muscles that surround the dysfunction become more powerful, and so do the tendons and ligaments. And there's a great piece of research on that also, so that even a damaged joint or a damaged bone can be better supported. And when it's better supported, there can be improved biomechanics. So, you know, a biomechanics specialist might see there's still a little bit head translation forward, and it's not perfect biomechanics in the post picture, though I haven't seen this woman in about a year. But it's a lot better than it was in the first picture. So her life is completely changed, and there's many other individuals. In fact, Jolene, who's just on the other side of the wall, her facility, there's 28 referring physicians referring to that facility, and there's been many individuals with this level of kyphosis who have reversed it, not quite in 7 weeks, maybe more like 7 months or a year or 2, but that type of result, and she can tell you a little bit about those. One more thing about joints that is more in reference to the previous slide. When a joint is compromised, when there is osteoarthritis, not to be confused with rheumatoid arthritis, there's cartilage damage, there's damage to the joint, there's pain. When you compress a joint at the level that we're experiencing the compression here, there's a great study in 1998 done by Benjamin and Ralphs. I met these guys. I thought they would be really funny. They're not funny at all. Louder? Oh, I can do that. So Benjamin and Ralphs, these 2 guys, it was a great study. They looked at the compression of joints under high impact level force or very abrupt force, and how it improved what they measured to be a fibrocartilage uptake, so the thickness of tendons and ligaments that surround a joint. So if you're bone on bone and there's pain, if you increase the thickness of the joint capsule and the surrounding tendons and ligaments, the joint can be supported better. You're still going to be bone on bone. The cartilage doesn't just show up again. But if there's better support to the joint, you can reduce the pain. And many people have, and you can see on the wall here, many people talk about massive reductions in pain. Maybe not going away completely, but going from debilitating pain to being very manageable pain without any painkillers or anti-inflammatories or things like that. So when would a physician refer? When would they say you should go check out OsteoStrong? Now, some of you are going to mention to your physician, hey, I'm doing this thing, OsteoStrong. Some will say, I don't know what that is. Some of them will say, Well, what is it? And you'll remember to say it's impact emulation. You guys can write that down. So, or you can just look confused and give them the website, and there's some pretty good information there too. But it's not necessarily for everyone. There's contraindications, so like acute joint pain, meaning inflammation, debilitating, like I can't move my elbow or neck or whatever, that's not time to start OsteoStrong. If you're unmedicated hypertensive, there's something called a pressor response that happens when you exert yourself at a certain level, and if you have out of control blood pressure, you got to take care of that first, or you can't use OsteoStrong. And anybody with muscular dystrophy is contraindicated also. Some patients, this is really important for the medical professionals in the room, some patients will need regular checkups. So something is going on in the body that had previously probably not happened in that patient population. So it's really important for the physician to take a look at the functional bone performance report. So when people leave here, they get emailed to them, or maybe a printout, depending on where the printer is, I guess. They get a report that shows what they were able to tolerate and or produce at day one, and then progressing from there. So as somebody goes through this program, they might be able to increase their functional bone performance through their whole body maybe by 200%. So when that happens, that means that the individual could potentially stop themselves or decelerate themselves if they miss a curb or a step. And so it's important for the physician to follow up and look at these functional bone performance numbers and maybe run some other tests and some other things in tandem so that they have better monitoring of the individual.
What did you call that? Impact what?
Emulation. Emulation.
Okay,
Yeah. So yeah, and what you want to say when they say I've never heard of that, it's the benefit of high impact without the risks, because we're doing very slow loading that's monitored by a computerized biofeedback system. Did you get all that?
Yeah.
Great.
That's good.
So is there, and this is another thing to remember, is there enough data? Now, the data that exists over the last well, since the 1970s, when DEXA became prevalent, and they started using DEXA scans to look at bone density in physical medicine intervention, this isn't necessarily attached to some kind of marketing message that any physicians are getting, but it's in the physical. It's been in the physical medicine journals over and over again since the 1970s. So, if you look at how many studies there have been to, in a clinical environment, put weighted vests, this is a really popular one, weighted vests, and have individuals jump off of things, or very calculated like leg press type things where they're only using a specific range of motion to get more load into certain joints. There's 25,400 peer-reviewed papers showing bone density gain. They're called mechanotransduction. That's the word they use in medical school to talk about putting force into bone and having it turn into an adaptation, having it be manifest in an adaptation in bone. There's 1.2 million people studied through the course of these various studies. And this is the most important part. 67% of participating cohorts, meaning the categories of people that were selected for the study, were over 50 years of age. So it is known that bone density can be affected. The data that we have that explains what this is, what it does, and how it can benefit people is actually a greater body of literature than most pharmaceuticals prescribe today. It's just not been presented because there wasn't a safe way to do it until right now.